All right. We're back at it. One of the best injuries, easiest to figure out, easy to go ahead and treat, medial collateral ligament sprains or tears, the MCL, also known as the tibial collateral ligament. So be aware of both of those. Actually, a really common injury, and you should know everything about this. So partial or complete tearing of the MCL, tibial collateral ligament of the knee, valgus force. The knee gets hit from the outside and pushed in. This is way more common than the varus force. Remember that the fibers of MCL are attached to the medial meniscus. They are often injured together. And if you are doing a good knee evaluation, you need to be assessing both or all ligaments around the knee, and you should be assessing the entire knee. MCL, ACL, PCL, LCL, meniscus, and then of course, looking for any muscular damage as well. Excuse me. Pretty common condition though that you should know really well. So incident, super common, 15 to 35, peak athletic years, roughly equal for males, men and women. There is some research that suggests that women have a more valgus shaped knee and maybe more predisposed. But as we normalize that data out, there's also research that suggests women may have weaker ligaments on average than men, and there could be ligament laxity associated with where they are in their menstrual cycle. So take that with a grain of salt. But at the end of the day, gender doesn't really matter too much. It's just if they have the injury, we have to go ahead and assess and treat that. So risk factors, contact sports or high velocity activities. Soccer is a key one. Basketball is another one. Baseball, football, any kind of place where you have a foot that can be firmly planted and you get hit from the outside. What else is a risk factor? Prior knee injuries or instability increases the likelihood of a future injury. We know this for all injuries. If it's concussion, shoulder dislocation, doesn't really matter. Once you've had an injury, you're more likely to have another injury in the future. Muscle strength and proprioceptive imbalances can be there as well. Overuse in swimmers, specifically a whip kick when they're whipping around. And I wouldn't give this as a rehab exercise to start. They can get back to it later, but that whip kick really gives a lot of valgus force. I had one patient actually last week talking about how they were swimming and that whip kick made their knee actually hurt. And I was like, yeah, it's because you have an MCL injury, and we didn't go over that. So we made sure to cover that for them. All right. History. Anything else I want to say? Yeah. History, acute medial knee pain. The person's going to point at the inside of their knee and then run their hand superior to inferior up and down is what they'll typically say. Rarely they may hear a pop. Usually they don't, but they might actually talk about how they got hit on the outside of their knee or their knee crumpled in towards the midline, something like that. Swelling, prior knee injuries. Do they have instability? Here is our grading scale for this, but I'll get through that in just a little bit. Inspection, possible antalgic limp, severity dependent, absolutely. If it's mild, they may not even limp at all, but more significant, they will have that limp for sure. Failed 4-step test, possible swelling or bruising when compared bilateral. Point tenderness over the MCL is your key finding. At one, what was he, like 16-year-old elite level basketball player coming in. I have educated him enough now that he can identify which ligament gets damaged if he hurts anything. And he came in and said, yeah, I think it's my MCL again because I jumped up, came down, got hit from the outside. And I'm like, yep, that sounds exactly like it was. So reaffirming to them that they are intelligent and educated and they know what to do is a great way to empower patients to, number one, recognize the injury. Number two, not develop a significant psychological response to it. And then number three, get them on the road to healing much sooner. So motion, active and passive range of motion may be limited due to pain. Resistant range of motion is usually within normal limits unless you're stressing the ligament a little bit. Neurovascular is rarely damaged in MCL injuries. There's not really major nerves or vascular structure through there. If they got really hard, the saphenous nerve, and yes, I'm saying saphenous nerve if you've forgotten your anatomy, not saphenous vein, the saphenous nerve can sometimes get clipped on the inside of the knee, but pretty rare injury. Differential diagnosis is going to be an avulsion or tibial plateau fracture. This is where more detailed diagnostic imaging might be warranted. Meniscus or ACL damage often coexist. And an ACL is injured in 20% of grade 1 injuries of the medial collateral ligament. And 78%, meniscus injuries occur in 5 to 25% of cases, probably a little bit higher than that, especially if the person has a lot of sport where they're playing with planting, twisting, cleated shoes, right? Vastus medialis oblique fibers, that VMO, they also can go into and be damaged in that area as well. So part of your rehab is assessment and evaluation of those muscles. Also why it's crucial that we're giving these active range of motion exercises as soon as possible. Grading this injury, what do we get? So grade 1, mild point tenderness right here, stress, at 30 degrees, might show a little bit of pain, but not too bad. This one recovers relatively quickly. And that 16-year-old I had, this is all that he had. It was a mild one. He was better in a week and a half, at least functional capacity better. All right. And then, of course, I told him and made sure that his coaches knew as well that not to overload the knee. He had to play in some provincial finals for the province here. So for him, it was just, hey, take it a little bit easier. Maybe just limit your game time just a little bit, like 25, 30%, just to make sure you're okay with it. Moderate, grade 2, possible bruising and swelling, more significant palpation tenderness. You might notice now on a stress test that the knee kind of clunks around a little bit more. It gives you a little bit more gapping. This one could take up to a month or longer to get better. And then grade 3, this is a bad injury right here. You can see how we've gone in and had an ACL rupture, medial meniscus, and that medial collateral ligament. They will have an empty end field. So you check the unaffected side, nice and tight. You show it to them. You come to the affected side and the knee just gaps open and they can totally feel that. That can put a lot of stress actually on the lateral collateral, well, not the lateral collateral ligament, the lateral meniscus as well, where you can increase your risk of meniscus tears out there. And this one may be months of healing time and rehab. And it's all about education and empowerment to get them back into their sport or activity that they want to perform. So here we can see the valgus stress test at 0. That kind of checks the main fibers running up and down. But as you flex, the medial collateral ligament is quite a bit wider than people realize. And you want to go through various ranges of motion to check it in multiple different planes. X-rays are indicated if you think there's a fracture. However, please remember, X-rays do not show you the ligaments themselves. MRI is not usually necessary to confirm, but if you had doubt and you wanted to look at it more closely, here is a picture of a acute grade 2 MCL sprain where you can see the water density or inflammatory density around it and a little bit of damage to the architecture of the actual ligament itself. Also, ultrasounds are fantastic. They're less costly. They can be less reliable if you have a tech or somebody who's looking at it who doesn't know what they're looking at quite as well. But I've seen some ultrasounds recently that look excellent, and you can move the knee around so you can see dynamic movements with it as well. So relatively cheap, ready to go with the diagnostic ultrasound. All right, MCL injury, what are you going to do? Number 1, biopsychosocial support. Make sure this person understands this condition, recognizes what they can and can't do, and has the right counseling support. Like a lot of people think these injuries are career-ending injuries, and in severe cases, they may very well be if they play a professional sport. But in a lot of cases, they're not, and people can get better from these. You're going to meth them up, so movement, exercise, traction, and heat. You're going to improve joint flexibility, reduce swelling, support the body's natural healing processes through diet and botanicals, and you're going to consider crutches, braces, or K-taping in the short term if it builds confidence for them to move their knee. Massage therapy is a great idea, working on areas of compensation, treating the unaffected side, then coming to the affected side. I'm a big fan of instrument-assisted techniques as well. What else can we do? Osseous mobs on areas of compensation you can work on. We could also be looking at gentle mobilization of the knee itself. Even this MCL test, I use it as an outcome marker. Every time the person comes in, I test them again and see how does it feel. And then we follow up again. Every time I'm challenging it, they can show me less pain. They can show me less gapping of the joint. Those are positive outcomes that you want to celebrate with that patient. Medications, consider prolo or injection therapies, grade 2 injuries, or if you're having poor luck with conservative management. Short-term NSAID use could be of benefit, but again, short-term, get them off it as quick as you can. Surgery, rarely required. Usually has to be done relatively quickly, or the damaged fibers wind up just being reabsorbed by the body's own inflammatory process and macrophages. Isolated MCL tears are usually treated non-operatively. This is pretty standard right here. MCL tears in combination with ACL meniscus lesions often require surgical reconstruction. So as the injury gets more significant, more acute and severe, then you would be looking at co-management with an orthopedic surgeon. Follow up, rehab, start with pain-free range of motion. Stationary bike or aquatic exercises are great. I especially recommend movement in a hot tub. As long as there's not too much inflammation, that heat in the area, and then just getting them to move back and forth, they can often move a little bit better in the freeing buoyancy of a hot tub. Open chain with gradually increasing weight as tolerated by patient. Progress to activity and sports-specific movements, proprioceptive retraining. Wobble boards are huge for this. In fact, the one player, the basketball player that I've been talking about here, We have wobble boards that we just give to our patients to use at home. And you could see when he first came in, he could barely balance on the one knee. And a week and a half later, he had excellent balance on that one leg, moving back and forth just from the wobble board and his own proprioceptive retraining. So that would be a prime example of education and empowerment and exercise that made that happen. Patient monitoring, orthopedic reevaluation within 2 days if significant instability. So again, have them follow up right away. You still want to rule out a fracture. So you might miss it earlier on, but in a couple of days, if it's still significantly tender, there's big black bruising, non-weight bearing, might be warranted to have an x-ray potentially. Splinting or crutches. Yeah, you can guide that on a case-by-case basis. Prevention and patient education, avoid the risk factors. So in this player right here for basketball, watching how they land for their jumps. Okay. So he was landing with a lot of valgus load over top. And sometimes it's hard because you get pushed in the air and all of this kind of stuff, but trying to land in a safer position might be key. Prophylactic knee bracing short-term might be key as well. And that's one thing that we recommend for this player when he was playing in these provincial tournaments here. Most patients with mild to moderate sprains return to full function within 3 months. Absolutely. Severe injuries can take 6 to 9 months before they are fully healed, and surgical repair will significantly prolong the healing process, but it may result in better outcomes. But it depends what's happened. Like if there was a meniscus tear, mastectomy was done, you can be looking at increased risk of osteoarthritis later in life as well. Within 10 years, we can see here. Expected older patients will heal more slowly. In pediatrics, careful evaluation of epiphyseal growth plates to make sure there's not any Salter Harris fractures there that could modify how well they heal. Now, for the exercise rehab, here's just a picture showing some massage therapy that you might do where you have the knee well supported as you work through the tissue. Some simple banding exercises, working deflection extension. One of the things that I give to strengthen up MCLs quite often is what's called a crossover lunge, or a sissy lunge, some people call it, but I don't like that name, so we're going to call it a crossover lunge. You have the person step past center, and in stepping past center, they are stressing their MCL a little bit more. They're also stressing their lateral meniscus, but as they stress and load in this direction, they should be able to handle those forces better. And as long as they're not unstable or causing more injury, this is a great way to load that in a dynamic manner, going through a flexion extension movement of the knee and stabilization of the hip that you might have to do in real life. Like if you slip on the ice, or if you're coming down and you get pushed a little bit from a jump, this would be a great way to load that MCL. All right, so there you can go ahead and see it. Fantastic condition of MCL. What do we want to do? We want to educate, empower, exercise, and get in there with our manual therapies to help as much as we can. All right, thank you very much for your time, and we will see you on the next video.